Hey everybody, I wanted to welcome you to the Indiana State Board of Animal Health's first lunch and learn of 2026. This one is special because it's the first of a three-part series on vaccine-preventable equine diseases. We're glad you're here and hope you can join us again for part 2 on March 11th and part 3 on March 25th. Both of these are at noon Eastern. Be sure to use the registration links for each of those. I'm Dr. Heather Solomon-Gabl, Equine Health Programs Director for the Board of Animal Health and veterinarian for West Central Indiana. We're excited to have a special guest presenter for this series. Dr. Ryan D. Rothenbuhler is a veterinarian and owner of Conley and Kuntz Equine Hospital in Columbia City, Indiana. He graduated from Purdue University College of Veterinary Medicine in 2001 and completed an equine internship at The Ohio State University in 2002. After that, he returned to Purdue to complete a large animal surgical residency and research training. In 2009, he became a diplomate of the American College of Veterinary Surgeons in Large Animal. Since then, he's been a partner at Conley & Kuntz Equine in Columbia City, Indiana. His professional interests include surgery, wound care, pain management, and lameness, especially in performance horses. And as a fun fact about Dr. Rothenbuhler, he was actually an intern here at BOAH while he was at Purdue. Just a couple housekeeping notes as we begin. After the presentation, we're happy to take as many questions as we can. Just use the chat feature to type your questions. In a few days after this webinar, we'll have the recording posted to the BOAH YouTube channel for those who are not able to watch live or if you want to review the information. Now, I want to welcome Dr. Ryan. I'll hand it off to you for your presentation.
Welcome, everybody. It's kind of weird doing this on a webinar. I've never actually stood in front of a camera or talked in front of a camera, but it looks like I'm the only one that actually has my camera on, so welcome to my dining room. Today we're going to talk about the mosquito, specifically the mosquito-borne viruses. I kind of approached Heather last year in goal of trying to get out and educate a fair amount of our clients in regard to preventable diseases and vaccinations. We have seen a fairly scary and remarkable drop in number of people vaccinating their horses or willingly vaccinating their horses, but also we have a fairly large community in our neck of Indiana, Northeast Indiana, that is fairly Amish driven, and we see a fair amount of vaccine preventable diseases on these farms. And I know that their Amish probably are not likely to see this webinar, but this was kind of it's a multifaceted approach that we're going to try, and Heather was all on board to have us do this webinar. So before we go any further, Heather did mention this is a three-part series. So today we're going to talk about the mosquito-borne viruses, specifically mostly West Nile and Eastern equine encephalitis. There is I'll give you a little bit of background. She mentioned where we're at. We are Conley and Kuntz Equine. We are a private referral hospital up in Northeast Indiana. You can see our Facebook page and our website. I throw a little pitch in here, but this is our hospital. I'm going to get through this pretty quick because I do want to reserve some time at the end for questions, but we are full service. We have a boarded internist. We have 5 veterinarians currently. We're adding our 6th veterinarian this June. So I'll get to the meat and potatoes of it. I threw in the zebra because this was a neurologic zebra that we saw presumptively was West Nile. So we do think that there's some crossover. Zebras are just like horses until they are stripes. So 3-part series. The next one is probably one of my favorite talks is core versus risk based vaccinations. We're going to cover that one on March 11th. And then on March 25th, we're going to cover strangles and outbreak prevention. One of the, I told you, is a multifaceted approach, but we have seen a significant increase in strangles over the last couple of years. There are parts of the state that don't see a lot of it, but we see it. If I say daily, I mean almost daily. So we take a lot of a lot of seriousness with strangle. So we'll cover that one on March 25th. Looking forward to talking to everybody on that one. So I already said, predominantly our U.S. mosquito-borne equine viruses that we see here in Indiana is West Nile and Eastern equine encephalitis. It's pretty much thought that Western equine encephalitis is west of the Mississippi predominantly. We do vaccinate for it throughout the United States. I'll talk a little bit about climate and some climate change, and definitely don't want to make this political in regards to climate change, but I do think it is important that we cover some of the thoughts that some of these diseases that we once thought were regional or seasonal are definitely changing. So we'll cover that a little bit. There are some places in the country that still vaccinate for Venezuelan equine encephalitis. I had to do some searching in regards to, I don't think I've ever actually sold a Venezuelan equine encephalitis vaccine. I think the last reported case was in Texas in maybe 1971. So I don't think it's a highly concerning virus in the United States. But as we see mosquito populations migrate farther and farther north from the south, I think that there may be a time where we need to consider vaccinating for Venezuelan throughout the United States. I'm not going to list through all the U.S. mosquito-borne human viruses. I will say that there's a fair amount of emergence of viruses that are mosquito-borne vectors throughout the United States. One that I put on the bottom here with an asterisk is Cache Valley. And this one hits home for me. It's a predominant sheep and goat virus, but there have been crossover into humans. And recently there is documentation of a neuroinvasive form of Cache Valley in horses. We do have Cache Valley in Indiana. We've seen it in Northeast Indiana. We have confirmed it with Diagnostics. So I'm a little worried that we may be seeing some emergence of viruses that may contribute to some of these mosquito-borne viruses in both our human and horse populations. But currently, the only ones we can vaccinate for are the ones that are listed on the left side of our screen. I mentioned it earlier, and I'll kind of deep dive into it a little bit in regards. I gave a talk last year to Indiana Veterinary Medical Association regarding very specifically climate change and the emergence of diseases that we once thought were seasonal or regional, and we're seeing diseases that are no longer seasonal. We see them throughout the year. We're starting to see viruses that we only thought were in Central America that are now creeping into Florida and Texas. I know Zika virus was a hot topic a few years ago in regards to mosquitoes in Florida. The mosquito that carries Zika virus has been found in southern Indiana. And so I think as we have climate changes, more extreme heat waves, less cold temperatures, and I know this winter is not a good example. I think weather volatility is more of a hot topic, but it's hard to talk about mosquitoes when we've had such a cold December and January this year, but even into February. But we see earlier spring thaws. We're seeing more water. We're having more extreme weather events, which lead to emergence of diseases, and that's where these mosquito-borne vector or viruses come from. So what do we predominantly look when we think of weather-related mosquito populations? We think of summer through early fall, and so when we right now talk about West Nile, when we talk about Eastern equine encephalitis, we'll dive into Potomac horse fever in our next topic. But we look at weather-related spread of disease. We think of the mosquito ones as summer and early fall. But with increased precipitation and warm weather, we see some seasonal variations in when we see some of these viruses. When we have dry springs and then wet spring, wet summer, we can see accelerated mosquito breeding. Some of these mosquitoes can reproduce in 5 days or less. We know that more standing water equals more breeding. Obviously, more opportunity for virus transmission if we have more standing water and accelerated breeding of mosquitoes. One thing that I put this paragraph over to the side is there was a published study. It was last year, I believe, and they looked at droughts throughout the United States and very specifically looked at mosquito-borne diseases, and they very specifically mentioned West Nile virus. And you would think of droughts as drying up water, drying up mosquitoes, but this was the conclusion paragraph, and I'll just read it, is droughts create a paradox. So they create a paradoxically event that doesn't make sense. And that's the idea behind the paradox, is that it doesn't make sense that if we have a drought, we should have less mosquitoes. But what it does is reduce the overall mosquito population by decreasing the water, decreasing the standing water. But it also increases the risk, because what it does is concentrate the mosquitoes in stagnant water population, but also animals tend to congregate, birds tend to congregate in those waters, therefore spreading it through mosquito and bird. So I think that there really is no more thoughts of wet season versus dry season. I think we've shown that birds, mosquitoes, humans, and horses, no matter if it's wet or dry, we have an increased risk for it. And my screen won't move. Hold on one second. So why does Indiana have West Nile? And we'll cover when it came to Indiana. It actually happened early in my career. We've been fighting it for a long time, but the map on the left is rivers. And so imagine all these blue lines, and this isn't the whole state of Indiana. I covered predominantly northern Indiana, because that's when West Nile first hit Indiana. That's where we saw it, was in northern Indiana. But every one of those rivers has tributaries and irrigation ditches and standing water coming off of them. And if you look to the map on the right, every one of those circles, and this is the map for taking your kid fishing. And so, but what I took from this map is every one of those circles is a public access point to standing water where there's fishing, which there potentially is available for mosquitoes. And so if you look at the state of Indiana as a whole, we might as well be blue. I think there's water pretty much everywhere. I would encourage, if you've never done it, is look in Northeast Indiana's map. There's 15 lakes within 15 miles of my house. And so every one of those lakes have standing water somewhere. So good breeding population for mosquitoes that spread both West Nile and Eastern encephalitis. These pesky mosquitoes, there's over 200 types of mosquitoes in the US, but only roughly 12 of them actually spread disease and germs. The nuisance ones, the ones that we typically associate with biting and being a problem or zipping around our ears, they're the ones that aren't spreading the germs. But as the CDC says in every one of their flyers on mosquitoes and controlling mosquitoes, is you can't tell which one spreads the germs, to protect yourself, or in our case, protect our horses. When we look at the primary disease vectors, the Culex species mosquitoes and the Closettos are the two predominant. The Aedes can spread and do spread. And I don't think that's super important, but it is a little bit important in the vector between mosquito and bird, and then horse and human. Horses and humans, for both of these diseases, are considered accidental dead-end host. There is no spreading of either one of those viruses once we have them or the horses have them. Our primary reservoir, and if you look at the screening throughout, is our birds tend to concentrate the virus. For whatever reason, crows are overly sensitive to West Nile, and so there is some testing that'll happen throughout the summer months when they find dead birds. Some people will look for West Nile. There is mosquito screening throughout the state of Indiana, throughout the country, specifically for West Nile and Eastern encephalitis. I didn't show any maps or graphs of positive mosquito or bird screening, but it is constantly being watched. One second note, I guess I'd mentioned Cache Valley. Currently, there is nobody screening for Cache Valley in the state of Indiana, so I do anticipate as that increases, I think we will start seeing it screening-wise. So the mosquito-borne ones we've already talked about is West Nile and Eastern encephalitis. West Nile, they're both arboviruses. West Nile is a Flaviviridae virus. It was first discovered in 1999 in the United States. We had our first cases of it in 2001 in Indiana. I will say I was a young veterinarian actually working at Purdue at the time. And when we didn't really know what this was, but we had stall after stall after stall throughout the hospital of horses that were in some phase of standing with neurologic disease to down and recumbent and unable to stand. And as students and residents, we just flipped horses over and over and over. A few of them would get in the sling, but for predominantly, we just had down horses and stalls that we were flipping. We really didn't have any, we knew what it was, but we really didn't have any great treatment. We'll talk about some treatment options here in a little bit. One thing that I thought was was interesting is that within just a few years, 3 years, it had spread entirely across the continental United States. It has been found in 150 different types of birds. So I don't think the bird is the predominant issue, but we just know that birds concentrate the viruses, allowing the mosquitoes to feed on them. And there are certain types of mosquitoes that predominantly feed on birds, but then there are bridge vector mosquitoes that will spread it to human and horse. Eastern equine encephalitis. Fortunately, I have never had a positive diagnosis on triple E. I'm pretty positive I've seen cases of it. We struggle at convincing our owners to do diagnostics, and so the few cases of ones that I suspect were triple E, they were more severe than what we traditionally see in West Nile, and so triple E is known as sleeping sickness, and what I will say is one of the more telling signs or the differences of where we suspect is that triple E horses, they act severely depressed. Unlike the West Nile horses, and we'll talk about some of the symptoms, but a lot of the West Nile horses will have almost normal mentation, but have neurologic disease. The horses that we suspect are sleeping sickness or triple E, they are severely depressed. They don't want to eat. They once they become recumbent, they go very quickly. It was first discovered in 1830 in a horse population in the United States. It was first isolated in 1933, and the first human case was in 1938. And I think there's a lot more, I guess, concern with triple E over West Nile is because of the mortality rate. We'll dive into that a little bit here in a second, but the big symptoms of both these viruses, and they're very similar. I think without diagnostics, you probably can't make a true diagnosis. We can just suspect or make a clinical diagnosis. But they all have fever, depression, lethargy, and neurologic symptoms. And the neurologic symptoms are pretty similar. We see it basically due to the inflammation of the brain and spinal cord. We'll see circling, stumbling, incoordination, recumbency. One thing that I see differently between triple E or suspected triple E cases versus West Nile is we see muscle fasciculation and tremor with West Nile that we don't necessarily see as severe with the triple E horses, and then just overall hypersensitivity. You clap your hands, these horses will sometimes fall over. So the transmission cycle or the life cycle of both these viruses is very similar. I just grabbed both of these off the CDC website, but basically you've got a mosquito vector that feeds on birds. The birds are amplifying host of the West Nile and triple E. And then there's bridge vectors that the types of mosquitoes that will take it from a bird. You might get it in a bird feeding of a different type of mosquito and spread it to horse and human. Most of the time, we don't see much death in humans. We see mostly just sick patients, but in horses, we do see a fair amount of death. But we'll talk about mortality in a second. But just know that the humans are bridge vectors. They are dead end host, and we cannot spread it. So the earliest symptoms, and I put a big asterisk at the bottom here, is we usually miss these symptoms. I would say the overwhelming majority of the cases that we have seen and diagnosed, the owner never found a fever, never really found them off feed, never really seen any depression or anything. They typically, and at least the West Nile cases that we've seen, they presented with muscle fasciculations, and I've got a video of a couple cases here in a second, but I did mention this earlier, but triple E seems to be more severe in regards to depression compared to West Nile. But again, we rarely see these symptoms. I think most owners miss the moment of fever. Most of these horses, at least in our experience, Conley and Kuntz, and what we remember from the Purdue days, is most of the West Nile horses will continue to eat. They almost have a normal mentation. They just have a neurologic disease. So typically how we present is they'll continue to eat. A lot of our recumbent horses want to get up, but they're just unable to get up. Whether this is true or not, when I first few cases I had at Purdue that I can remember, they didn't want to use their front end, but their hind end would try to get up. And what we're seeing now is mostly hind end. We'll see a lot of these horses dog sitting. You can imagine a dog sitting, right? They're down on their rear end and their front legs are up and their head is up. And a lot of our West Nile horses present to us as dog sitting and unable to rise. If you assist them, use a tail rope, use a a sling, a forklift, something to get them up. They'll stand until they can't stand again, and then they'll fall again. But a lot of these horses, they want to stand, they want to be standing, but they just can't do it. Severe muscle fasciculations and tremors is the predominant presentation that we see on the initial clinical exam. One thing that I think, and I put this last line in here, is the third eyelid does not protrude. So tetanus will frequently show up as tremors or excitability. But one thing that is different that we see with tetanus that we don't see with West Nile is the third eyelid flickering back and forth across the eye. So tetanus cases, you make a loud noise, their third eyelid will flutter. We do not see that, or does not appear to happen as often with West Nile virus. So this is a pony that presented to us in September. You can see the head trembling. This pony was eating, drinking, did not have a fever. Unknown vaccine history. Owner had purchased 5 horses from 5 different locations with an unknown vaccine history. I will tell you clinically, this horse responded to therapy for about 5 days, and then was found recumbent and unable to rise on day 9, where we euthanized it and submitted testing, and it was positive for West Nile. The second horse over here was found recumbent, and that is not smoke, that's sawdust. They're trying to bed the eye away because she actually walked in with muscle fasciculations, and you can see her head trembling. But one thing that I will say is when you look at her ears, you look at the way her face is moving, she's actually, mentation wise, she's bright, she's alert, she wants to look around, she wants to do it, but she can't. In regards to this case, she was found recumbent with muscle fasciculations. They made their own sling, used a bobcat, got her on her feet. She lived for about 3 days, did really well, and they would lift her up every day. They would keep her on her feet, and then they would find her down sometime during the day. They did that for 3 days, and then on day 4 they euthanized her, and she did test positive for West Nile as well. The hard ones are I want to say the symptoms that result in euthanasia. The ones that are down, the ones that are recumbent, it's very costly. Keeping a horse around 24-hour care, managing them in a sling, managing them in a padded stall, it gets very expensive. And so we lose a lot of these due to money. But if somebody's committed financially, and I show the picture here, this was a 2-year-old unvaccinated horse. A very knowledgeable owner, honestly, just didn't think about vaccinating, and she let it get away from her. She didn't vaccinate her horse for West Nile. This horse was presented with muscle fasciculations, and for 14 days, we would sling this horse to stand daily. When it got tired, we would lower it back down. It spent majority of the first, I would say, 7 to 10 days. I did not ask Dr. Grand for the whole clinical timeline here, but I want to say 7 to 10 days before she finally he stood up on his own and fully recovered. And so they can, at least with West Nile, we've been successful in some of the cases if they stay on their feet. This is our only one that we have ever saved. So I've been practicing for 25 years. Dr. Grand's been doing it less than me. Dr. Kuntz has been doing it longer than me. But historically, once they go recumbent, we rarely keep them alive. This is a perfect example of this owner was committed financially, and we managed to get this one home to her. And that horse is actually is a performance horse and is competing with no neurologic deficits at all. So it can happen. I mentioned throughout is when we look at EEE and West Nile, the death rate of EEE is almost 100%. And I say almost 100%. And this range came from a retrospective study looking at other studies, and the range was anywhere from 75 to 100%. I would tell you in generic fashion, it's 100%. West Nile, if they stay standing, success at treatment can be the mortality rate can be as low as 25 to 35%. Once they go recumbent, the mortality rate is pretty high with West Nile. I would say this 60 to 80% came from the AEP. I would say once they go recumbent in our hands, it's almost near 100%, except for our one case that you see here in the picture. And I'll go back to that one. This was 24-hour care. You can see we've got 2 two assistants in here, and this horse was around the clock care for 14 days. And I think the bigger challenge is keeping them from hurting themselves. And so we actually manage this one in our padded recovery stall. So we actually we have two induction recovery stalls. So we actually managed her or him in our padded recovery stall so he wouldn't hurt himself. Diagnostics are tough. Clinical signs are probably our biggest diagnostic. I'm just about 100% on clinical signs. If it walks and talks like West Nile, it's West Nile. But typically, if we're going to do some submission of samples, we look at IgM capture ELISA, and this is looking at specifically antibodies. It is the preferred live animal diagnostic because PCR is specifically looking for the viral particles, and the problem with that is it's in the brain and in the spinal cord, and so it's very difficult to do PCR on blood. Last time I looked, Purdue was only doing PCR. I don't believe they had an IgM capture test. We actually submit ours through EDS. You can do serial samples if you're concerned about vaccination versus active disease, but fortunately, we have never had a vaccinated horse come down with West Nile. So all of our samples with our IgMs that we submit, they're on unvaccinated patients. So if we see a positive, it's pretty obvious that it's West Nile. You can test cerebral spinal fluid looking for the antibodies, but it's an invasive test, and blood seems to be the best route for getting a test. We do, as I said, we do most of ours through EDS out of Kentucky. PCR is the preferred diagnostic after death. So if you have one that's down, gets euthanized, you really want to know brain or spinal cord tissue through Purdue ADDL is an acceptable test and a fairly inexpensive test. I just pulled a couple maps. This is the EEE map on the left. We didn't have, but we only had one reported EEE in Indiana last year, according to the Department of Health website. I know in years past it's been higher. I flipped through year by year, and it didn't get very high. It pretty much stayed in the 1-2 kind of number for triple E. The West Nile one on the right is a little. I will say it's low. We probably euthanized as many horses or total on that map that we didn't get testing on. It's not a we try telling our owners to do diagnostics and to do testing, but we have a population of owners that when you tell them they have to do something, they're less likely to do it. So we try to convince them that it's good to do the testing, but it doesn't always happen. If you look at the Adams County 20 horses down there, I actually asked Dr. Solomon the other day who did that, and that was the one vet hospital, and she said they just tell them they have to do it, and good for them. We play that similar card. It doesn't work in our hands, but I mean, I don't know that Adams County had 15 more horses than Allen County, but what I will say is that they did a really good job at diagnostics, and we didn't do as good a job on diagnostics as they did. And so I think the number is a lot higher than it is in both EEE and West Nile, but we are in an area that doesn't allow a lot of forced diagnostics. Unless it becomes a regulatory issue, we can't force them to do it. I pulled this paper. I've given lots of vaccine talks over the years, and this is a DVM 360 article back in 2011, and I pulled it. I didn't give a whole lot of the information, but I'll talk a little bit about it. It is in 2009, Michigan had 0 cases of triple E. In 2008, they had 1. In 2010, they had 55 confirmed, 130 suspect cases. Now, you ask yourself, why did they have such an increase? And the state veterinarian blamed skimping on vaccinations. Well, if you can remember 2008, 2009, we were in an economic time where people were really cutting back on vaccines because of money. And I think his assessment was probably right, is they're skimping on vaccines for various reasons, whether it was money, whether it was gross neglect where they just forgot about it or whatever. But I think coming out of a recession was a good indication that people weren't spending money on vaccines, but it goes to show how effective the vaccine is. To go from 0 1 year to 55 the next, that is a giant concern of mine, is that we have effective vaccines, and if we don't use them, we're going to end up with big outbreaks and clusters like this. Treatment, again, most of the time you're treating West Nile virus, and so I think the treatment is very similar across the board for both diseases, but in general, we use a lot of dexamethasone. We use a lot of Banamine. I think if you're looking at neurological inflammation, the Banamine is less important than the dexamethasone is. We continue to use intravenous DMSO and mannitol. DMSO is a free radical scavenger. Mannitol is an osmotic agent that helps decrease brain swelling and spinal cord swelling. And so when we're looking at spinal cord and brain swelling due to a virus, I think the mannitol is important. Back in the early 2000s, when we were treating these, we really didn't know what to treat them with. We were using some interferon. As far as I know, it's not currently readily available, but it was helpful. But I would say the biggest thing that we do now as veterinarians is the steroids. We treat these, we go on farm for 3 days in a row, sometimes 4 or 5 days, depending on how they're doing, and treat them with intravenous dexamethasone, intravenous DMSO, and mannitol for 3 to 5 days. As I said earlier, the ones that stay standing continue to usually stay standing and do well. Once they become recumbent, we have had very little success. If they do become recumbent, we do sling to stand. Years ago, Dr. Hawkins and I at Purdue managed a fracture in a sling for a couple months, and we realized that there's some negative effects to living in a sling unsupported, or ground limbs not supporting themselves, that can lead to some complications that probably aren't good. And so I do recommend maintaining in a sling for a few hours until they get tired, and then lowering them back down to the ground. Letting them be recumbent for a period of time, and then slinging them to stand, gets them back up and moving. Bed heavily and roll frequently. As I started out by saying, we rolled horses when it was at Purdue in the early 2000s. I felt like all we did was roll horses. But if you're going to try to treat a recumbent one, you need to make sure that we're taking care of them on the ground. Prevention. So the meat and potatoes of what we're talking about here today is, I believe very strongly about spring vaccination. I like to see a month before mosquitoes. The problem is when do we see mosquitoes? It changes all the time. So I like to be right now be thinking about vaccines. I think February, March is a good time to be getting our animals vaccinated before we see these mosquito populations coming back to life. If you look at the majority of the vaccines that are out there, most of them require it annually. Most of them have a guarantee for annual vaccination, meaning that if you vaccinate it appropriately by a veterinarian, that they'll give you some sort of money towards diagnosis and treatment if your horse comes down with the disease. We at Conley and Kuntz do biannual vaccination, and we are in an endemic area. If you read the literature on the vaccine, specifically from the vaccine companies, they recommend that if you are in areas that are high in West Nile virus, that you recommend at least twice a year. So what we do at Conley and Kuntz is we try to get a vaccine in the early spring before mosquitoes are popular, our population increases, and then we try again in late summer. So we're not getting in exactly 6 months. It's hard to fit 6 months in depending on how everybody vaccinates, but we try to get a second vaccine in before peak season. It appears that peak season is probably September. I did not look at the graphs from Department of Health, but I would say in general, September is what we feel is the busy month for West Nile. Some people believe, and you can do this depending on how concerned you are, is multivalent vaccine versus monovalent vaccine. There's some discussion out there that antigenic response to multivalent vaccines are not as effective as a monovalent vaccine. And so when we're giving a 6-way vaccine, are we getting adequate protection on a single vaccine for a high infection rate of West Nile? And so we give a monovalent West Nile at our booster. I do have some barns that give monovalent West Nile in the spring and monovalent West Nile in the fall or late summer. to try to have extra protection from it. I think vaccinating non-vaccinated horses, if you go back and look at some of the literature, some people believe you need to vaccinate non-vaccinated horses 4 months before peak season. And so what I would say is 2 vaccines, 30 days apart. So, try to get something like a February and a March in, and that way, by the time we get into peak season, they have got all the antibodies that they can get from those. We do not booster Triple E, mostly because we don't see a lot of Triple E in our area. I know that the vaccine is guaranteed for a year, and so I question a little bit of, well, we say that we need to booster West Nile, but we don't booster EEE. And I think with Triple E, I think you could make that same claim that we probably should be boostering. We have chose as a practice to not do it if we started to see more increase of it or more issues. And then I think the biggest thing that none of us do very well is environmental protection. We vaccinate our horses, but we don't do a lot to prevent the mosquito population. And so reducing mosquito population means getting rid of stagnant water, changing our water troughs. If we've got creeks or ponds, keeping that water moving. Fans in the barns. Mosquitoes won't land on your animal if they've got fans blowing on them. I think keeping them in the barn dusk till dawn. It's not perfect in the barn, but it reduces. I tell you what, a horse out on pasture comes in with 1 million mosquito bites. A horse in the barn may have 3 or 4. And so I think it increases our chances of these mosquito-borne viruses if we're leaving them out all night. So if we can bring them into the barn, keeping them under fans, using some topical insecticides, not being afraid of fly sprays or topical oils. I think a lot of the natural products are good for fly repellents. I'm not sure they're good enough for mosquitoes. And so I do believe in actual chemical insecticides for reducing the mosquito population on our animals. One thing that is I talk about reducing mosquitoes is during peak breeding season or accelerated breeding season, these mosquitoes can become biting adults in 5 days. It does not take much water to reproduce. They just need a standing 1/4 inch of water that doesn't dry up in that 5-day period. I go around farms all the time and tell them to get rid of buckets and tires and old troughs and anything that holds standing water, get rid of it. Improve drainage. If you've got muck ground that is holding water in peak season, try to get a field tile, get something to get the swampy water reduced off your farm. Retaining ponds, they need to be moving. So putting aerators, putting fountains in them to keep the water moving. Mosquitoes will not reproduce in moving water. You can add mosquito fish, or basically add mosquito predators to your water troughs. A lot of clients will put goldfish in their water tanks. We have services now that we didn't have 25 years ago. We got mosquito spraying services now that will come and actually spray your pasture, your backyards. Fans in congregation areas. There's some golf course fans that they use in the southern states that are oscillating fans. I like those in turnout lots just to reduce any stagnant air. Keeps the air moving around and mosquitoes are less likely to land. And then again, I'm going to harp on this: dusk till dawn in the barn if you can. Anybody have any questions? I've talked a lot. I went fast. I hope to have some questions. So anybody has any questions, let me know.
Hey, Ryan, we don't have anything in the chat so far, but I have a question for you. I don't know if you'll have an answer, but for those horses that do recover from West Nile, how long are those antibodies protective for?
Nobody, as far as I know, we have never in our practice tested the looking at IgM specifically. What I will say is the horses that are vaccinated, we have followed. I have some clients now looking at titers, and I will say the vaccinated horses, their titers remain active for a very, very long time. I would imagine clinical cases are a lot longer. I don't have a strong answer to say, but I do have some barns where we have not vaccinated multiple years in a row because of a bad anaphylactic reaction, or I have one horse that colics every time he receives West Nile and vaccine. And we followed his titer. We actually do his titer twice a year. Owner is all in on titer testing, and we don't know what protective titers are. I'll add that in. And so what we've done is monitored his titer after his last vaccine. We've monitored his titer twice a year, and he has not dropped at all. And so we feel like he's got a lot of protection. Again, as in all titers, is what's protective and what's not. So I always tell people to, if you can vaccinate, vaccinate. And while Heather's reading some other questions, I want to say this was not the smallest population of attendees I've ever had. So thank you all for attending. I gave a lecture one time to 3 people at the Hoosier Horse Fair, and that was very disappointing. So I'm glad everybody came today.
Okay. Looks like we do have a few questions. The first one is there a way to get the slides from this presentation?
I have nothing that's proprietary in my slides. I did not put references in. So if you're going to look for references, I did not put references in. But if Heather's okay with it, I have no problem sharing them.
Yep. This video will also be on YouTube, so you'll be able to view the slides there. We have another question. When you discussed IV treatment, when do you start? What is the duration, and when can you determine / see potential response for evaluating prognosis?
Wow, that was a lot. Hold on. I'm going to turn my speaker up because I did not hear everything. All right, Jared, do me a favor. Tell me the first part of that question again.
When you discussed IV treatment, when do you start?
We started immediately. We very specifically, the first time we see them, we start them on IV DMSO, mannitol. We do IV DMSO and mannitol just once a day, mostly out of convenience. You can do DMSO twice a day. It needs to be diluted appropriately. It needs to be administered appropriately. We do, there's some, I'll say, safety concerns in regards to the use of DMSO in both the patient and the administrator. We wear gloves and try to make sure we don't spill it on ourselves that way. But we do IV dexamethasone, IV DMSO mannitol once a day for 3 to 5 days. As soon as we see muscle fasciculations, I'll be honest with you, if I see a horse with muscle fasciculations in July, August, September, October, 100% of them are going on to West Nile therapy or EE therapy. I mean, we're going to start at day 1. We don't wait for test. If you wait for the diagnostic, they're going to be recumbent before you get your diagnostic back. The EDS is really good about getting it over. If you get it to them overnight, you'll have results the next night. So it's about 27 hours. But if one is to wait for diagnostics, I think you're already a day behind. And so I think all that therapy is very, very safe. And so if you suspect it, you need to start it on it right away.
Kind of the second part to that is for the same IV treatment, what is the duration, and when can you determine / see the potential response for evaluating prognosis?
So I will say it's rare that we're going to see response right away. Most of the cases that if we catch it early, you'll see some sort of clinical response within 12 to 24 hours. Sometimes they don't progress. It's not necessarily back to normal. It's they didn't progress. And so my very positive is, and I always tell people, is if I keep them on their feet for 3 days with treatment for 3 days, I feel very good about those horses in general making a recovery. However, this year we've had multiple cases that managed to get to day 3, looked great, found down recumbent, and were euthanized a few days later. And that the painted up little mini pony is a perfect example. That pony actually looked almost completely normal on day 3. Went back for we did a day 4 treatment. We did a day 5 treatment because the owner was all on board. And then that horse was found down and was euthanized subsequently from that. So in general, quick response, usually through not progressing, no perfect answer on how long treatment and how they're going to make a recovery or not, because we've seen a lot of change in some of the diseases that we're treating, and this is one of them that I would say it's not as fast. We are seeing more mild symptoms that maybe aren't progressing as fast as they did 25 years ago.
Okay. Thank you for that. We have another question. DMSO uses, DMSO use benefits and risks, question mark. I've had female doctors afraid to use it due to cancer risk.
I'm not going to deep dive into the historical perspective of DMSO, but there wasn't a professional athlete in the 60s and 70s that didn't paint this on their skin after every football game or every baseball game. And so it was used very, very heavily in human populations many, many years ago. It is a potent free radical scavenger, but it is also, by its purest definition, an industrial solvent. And so it comes with risk. There are some places that no longer use it. The majority of veterinarians that I know, excluding Purdue, I think Purdue is pretty much off of DMSO, but we continue to use it. We wear gloves. We don't have our owners administer it. We take precautions. What I will tell you is one drop on your skin, you can taste it. And so it absorbs that rapidly. You need to take precautions when doing it. I don't wear safety glasses when we use it, but some people will go as far as wearing safety glasses, but we wear gloves and try to keep it as contained and clean up any drops or spills that happen. As far as I know, I've not had in my clinical career, I've not had anybody with any concern of it. I've seen an overdose in horses lead to death in horses because it causes their red cells to rupture. And so if dosed appropriately, it's used very safe. Dosed inappropriately, it's not. And I've seen some owners give it inappropriately on their own and lead to death because of basically the red cells just pop and they die of anemia.
All right, thank you for that. I'm not seeing any more questions from the chat.
I did want to just point out one thing or confirm one thing for our timeline for vaccinating. I think you said 4 months before mosquito season, and just to give everyone an idea.
4 months before peak season.
Peak season, okay. Just to give everyone an idea of when we got our confirmed positive cases, our first one this past year was the end of July, and then our last one was the end of October. But I can confirm the majority happened in between August and September, kind of like a 50-50 split, at least for this year, on the timing of those, at least for the confirmed cases. So if that's helpful for anyone.
I am not going to harp on climate change, but I do believe in emergence of diseases that I believe that seasonality is going to go by the wayside as we have resistant populations to treatment of both getting rid of the mosquito population. We're seeing emergence of mosquitoes. Last week we had 50-degree days. We already got ticks. And so I think we need to always be considering is that, as Heather just listed off the time frame, I think July to September is our peak season of what we've traditionally seen. I'm concerned that if we have a mild spring, that we see mosquitoes earlier, and I'm harping on trying to get those horses vaccinated earlier and boostering appropriately if needed.
Looks like Greenlee put a link in the chat for their mosquito-borne activity dashboard. So if you're part of this team meeting, that'll stay there. You can use that.
All right. I don't think we have any more questions for now. Thanks, Ryan. We really appreciate it.
No worries.
Just want to remind everyone to join us for the next 2 presentations in the series. And this presentation and the questions and answers will be available on our BOA's YouTube channel if you want to review it for the future or send it to someone you know who missed presentation. So
I will just give a little bit of a precursor to our next one. We're going to spend a lot of time talking about core versus risk, but my plan is to hammer on EHV1 and tetanus for the most part, but also Potomac. And so we will cover a lot of them, but those three are the main ones that I'm gonna really hammer on. So hopefully, I think EHV1 is a very hot topic, but maybe an overblown topic. But Potomac isn't one that's overblown. We're seeing a lot more of that. So let's look forward to talking in a couple weeks.
Okay, all right, we're looking forward to it over here.
thanks, Ryan.
Thank you all.